this episode of Innovative Anatomy, we will be looking at the anatomy of the respiratory system. The respiratory system serves as the body's powerhouse of oxygen and carbon dioxide exchange, which is essential for cells of the body to function. Failure of the lungs to perform this vital function due to disease is an important cause of morbidity and mortality. Air first passes through a series of tubes and passageways, known as the upper airway, before it reaches the lung. This is comprised of the nose and mouth, pharynx, larynx, and trachea. When you inhale, air first rushes through the nasal cavity. Hairs and sticky mucus filter out dust and particles. Bony ridges called conchae, which are lined by mucous membrane, warm and moistens the air before reaching the pharynx, which is divided into 3 separate regions. The nasopharynx at the back of the nasal cavity, the oropharynx, which is what you see when you shine a light to the back of the throat, and the laryngopharynx, just above the vocal cords. Below the pharynx sits the larynx, which is located anterior to the inferior portion of the pharynx and superior to the trachea. The function of the larynx is threefold. Firstly, it acts as a passageway for air during breathing. The larynx is involved in the production of sound, and it also protects the respiratory system by preventing foreign matter from entering the airways. The larynx is suspended from the U-shaped hyoid bone at the base of the tongue via the thyrohyoid membrane and the thyrohyoid muscle. It is made up of 6 cartilages. 3 are large unpaired cartilages, the cricoid, thyroid, and epiglottis, and 3 smaller cartilages which come in pairs: the arytenoid, cuniculate, and cuneiform cartilages. The epiglottis is a leaf-shaped cartilage attached to the thyroid cartilage, which flaps over the top of the larynx when we swallow, to block off the trachea and prevent food and other foreign bodies from entering the lungs. It does this by moving upwards and forward. It's directly attached to the hyoid bone via the hyoepiglottic ligament. Below this sits the thyroid cartilage, which is the laryngeal prominence known as the Adam's apple. The cartilage is a semicircular shape that is open posteriorly. It's attached to the hyoid bone via its 2 superior horns. Inferiorly, the cricoid cartilage forms a complete ring and is attached to the trachea via the cricotrachea ligament. The 2 arytenoid and cuniculate cartilages sit on top of the cricoid cartilage posteriorly. The vocal ligaments are attached to the front of the arytenoid cartilage and back of the thyroid cartilage. The vocal ligaments, known as the true vocal cords, are made up of the thickened free border of the lateral cricothyroid ligament, which extends upwards from the upper border of the cricoid cartilage. The false vocal cord, known as the vestibular ligament, is made up of the thickened free inferior border of the quadrangular membrane. It sits just above and laterally to the vocal ligaments and is also attached to the arytenoid and thyroid cartilage. The mucosa of the larynx wraps itself around these ligaments to form the vocal cords. The movement of the vocal folds, which involves changing the shape, position and tension of the chords, is facilitated by the intrinsic muscles of the larynx. This alters the pitch and tone of sound. The external branch of the superior laryngeal nerve innervates the cricothyroid muscle. The remaining muscles of the larynx are innervated by the right and left recurrent laryngeal nerves, and these are all branches of the vagus nerve. The left recurrent laryngeal nerve travels a long course, which extends down into the chest and loops under the arch of the aorta to return to the larynx. The right recurrent laryngeal nerve, on the other hand, is shorter and loops around the subclavian artery. Consequently, the left nerve is more susceptible to damage from any disease processes in the thoracic cavity. Damage to either of the recurrent laryngeal nerves can cause the vocal cord on the affected side to become paralysed, and this leads to voice change and hoarseness. The trachea extends from the larynx into the thoracic cavity and sits anterior to the esophagus. It is held open by D-shaped rings of cartilage. It then bifurcates at the level of the carina at T4. It divides into the left main bronchus and right main bronchus, which is wider and more vertical than the left. Because of this, there is a greater tendency for foreign bodies and aspirated material to pass into the right bronchus rather than the left. A bit like a tree, these then branch off into lobar bronchi and then divide into segmental bronchi, which each provide air to a bronchopulmonary segment of the lung. These bronchi eventually divide into the smaller bronchioles. And eventually the bronchioles form alveolar ducts surrounded by millions of alveoli. Gas exchange only occurs at the alveoli, which have a huge surface area for diffusion and are lined by one cell-thick, simple squamous epithelium to allow for rapid oxygen and carbon dioxide exchange. Surrounding each alveolus is a pulmonary capillary bed. In chronic conditions like emphysema, the walls between many of the air sacs are damaged and there is depletion of this vascular bed. These damaged large air sacs can be seen on this CT scan of a patient suffering from COPD. These large air sacs are called bullae. As a result, the air sacs lose their shape. This damage can also destroy the walls of the air sacs, leading to fewer and larger air sacs instead of many small ones. There is a loss of surface area for gas exchange, and if this happens, the overall amount of gas exchange in the lungs is reduced. The right lung is slightly larger than the left and is divided into 3 lobes, the upper, middle and lower, by horizontal and oblique fissures. The left lung only has 2 lobes, separated by the oblique fissure. Each lobe of the lung is subdivided into bronchopulmonary segments, and each segment is supplied by a segmental bronchus, artery and vein. The right lung is made up of 10 segments and the left lung has 8. The lungs themselves are covered with pleural membranes. The visceral pleura coats the outside of the lungs, and the parietal pleura lines the inside of the ribs, the upper surface of the diaphragm, and the sides of the pericardium and mediastinum. The space between the membranes is known as the pleural cavity. The pleural layers are normally in close apposition. There is no air between them, only serous fluid called surfactant. This is secreted into the pleural cavity and acts as a lubricant, allowing the two membranes to slide against each other without friction when the lung expands. Because there is no air between the pleural layers, this then creates a negative intrathoracic pressure that sucks the lungs up towards the ribs and keeps them expanded. Without this negative pressure, the lungs would collapse due to their elasticity. Here you can see a thoracoscopy procedure taking place. Air has intentionally been introduced into the pleural cavity and a camera inserted to visualize the visceral and parietal membranes. This patient has abnormal deposits surrounded by prominent vasculature within the pleural membranes. This is suspicious of possible lung cancer metastases. There are certain pathologies you will come across frequently that disrupts the pleural layers. A pleural effusion is an abnormal accumulation of excess fluid in the pleural space. This chest radiograph shows a patient with a left-sided pleural effusion. Here, an ultrasound scan shows a large pleural effusion which has caused the lung to collapse. If air enters the pleural space, the negative pressure sucking the lung up towards the thoracic wall is lost. The lung therefore pulls away from the chest wall and collapses, causing a pneumothorax. The lungs are innervated by the posterior and anterior pulmonary nerve plexus, which sit behind and in front of the nerve root respectively. The plexi are made up of sympathetic and parasympathetic nerve fibres. Visceral pleura and lung are all supplied by the bronchial arteries, which arise from the descending aorta. The bronchial veins provide venous drainage.
This is a triangular-shaped area on the medial aspect of each lung, superior and posterior to the cardiac impression, lying between the path of the phrenic and vagus nerves as they pass through the mediastinum. It is the site of entrance and exit for everything going into and out of each lung. The structures that form each hilum are the right and left pulmonary arteries, pulmonary veins, bronchi and bronchial vessels, pulmonary nerves, and lymph nodes. The hilum is also referred to as the root of the lung, as it is the point that anchors the lungs to the heart and trachea. We will now look at the anatomy of the vessels that form the hilum and consider their relations to the heart. Each hilum has a pulmonary artery, originating from the main pulmonary artery supplying deoxygenated blood from the right ventricle. Oxygenated blood is then returned to the left atrium via two pulmonary veins, the superior and inferior. We can consider this anatomy in context by looking at this 3D reconstruction of a CT of the heart. Anteriorly, we can see the pulmonary arteries passing under the arch of the aorta, and posteriorly, we can clearly see the pulmonary arteries and veins entering the hilum of each lung. We can also see the major structures meeting to form the hilum on this coronal CT, which shows the trachea and pulmonary arteries. The hilum and other major structures can also be appreciated on a chest X-ray. The hilum is appreciated on a chest X-ray as the densities superior and lateral to the heart borders. The left is usually higher than the right. On the normal chest X-ray, the hilum will be appreciated as a concave density, where structures are branching to different lobes of the lung. Enlargement of these hilar shadows and loss of the concave appearance can suggest pathology at the hilum. Causes of this could be due to enlarged lymph nodes from metastatic disease or engorgement of the pulmonary vessels from pulmonary hypertension.
In this episode, we have examined the structure and function of the respiratory system. You can consolidate your knowledge on this subject by working through the multiple choice questions related to this episode.